Welcome to another episode of Scoop Insight. I am Julie Jalaluddin. Joining me is Azim Idris.
Hello.
Hi. Now, today we have a special guest from the medical and healthcare industry, Dr. Thirunavukarasu Rajoo. The newly elected president of the Malaysian Medical Association, MMA, a respected physician and advocate for healthcare reform, Dr. Arasu steps into leadership at a time when Malaysia's health system is under intense scrutiny, from burnout among junior doctors to the need for fairer fee structures and a stronger policy engagement. Now, in this episode, we'll unpack his vision for empowering doctors, protecting practitioners from workplace hostility, and ensuring that medical expertise drives national health policy, not just rubber stamps it. So, if you care about the future of healthcare in Malaysia, this is a conversation you won't want to miss. Now, Dr. Arasu, we appreciate it so much you coming here today.
Thank you, Julie, and thank you, Azim, for inviting. It's indeed a privilege to be here as well. Yes. Since I heard that your target audience are all the younger generation and they are the future of the country anyway. They're not the future, actually, they are the current leaders of the country.
Current
yes,
leaders of the country.
Yes. Exactly. So, with that, they need to understand what's really going on.
Yes.
So we will discuss matters of healthcare and medical as simple as possible for everyone's digestion. Now, how would you describe the state of Malaysia's healthcare system right now, heading into the budget 2026?
Yeah. Okay, to be fair to the healthcare system, right? Of course, our healthcare system has progressed very well since post-independence. We must remember the system that was designed for the 1970s problem has achieved its objective in reduction of the maternal mortality, infant mortality, and also access to healthcare across the country.
Right.
Now the issue is that the 1970s model is facing the current 2025 and beyond challenges. So that is why what was designed in the past, it needs to go through overhaul and reform so that we are ready, future ready ourselves for now and future.
So with that, what do you think is the biggest pain points you think the government needs to address, though? Maybe for both doctors and also patients?
Yeah. You see the biggest pain point, right? Okay, let's look at the patient first. Because the entire system is there today for the patient. We are either a patient or we'll be a patient one day, right? So as a patient, what do we look for? We want familiarity. We want easy access. We want convenience. That's what we're looking for. And quality of care, right? Yeah. As long as we get there, we are okay. But for us, so who is the contact person for these patients? From the counter, the nurses, the registry, if they go to the clinic, could be doctors. The what are doctors? So, of course, you have the medical assistants, even ambulance drivers, so on and so forth, right?
Yep.
So, we must ensure the workforce.
Yep.
Number one is the workforce. We must remember, in the 1960s and 70s, was the facility canggih? No. But the workforce was there. You can have a beautiful high-tech facility, but if there's no high touch over there, if you do not give importance to the high touch, it's not going to work. Patients are coming to see people in the facilities. So definitely, we must make sure the health workforce is our number one priority, and then we must take care of them.
So obviously you're saying that the workforce is currently insufficient, especially for the public healthcare sector.
Okay, this is not what I say. This is what the government's Auditor General said before COVID. They are understaffed, underfunded, and overworked. And it's the same. Pre-COVID, post-COVID, it has only got worsened.
Yeah.
So how does the budget attempt to address this at the very least?
Yeah.
Okay, to be fair to the government, I'm also critic, but I have to be fair to the government. Obviously, this is a legacy issue. When legacy issues, you can't solve things immediately.
Yeah.
Okay, you have to see what are the low-hanging ones you can solve.
Yeah.
As I mentioned earlier, workforce, right? To be fair, of course, they've given a permanent post for the nurses. And they've announced 4,500 plus permanent posts for the contract doctors.
Right.
So what we are asking is that we do not want it to be in a yearly budget. Abolish the contract system and start back the permanent system, how it was before 2016. The contract system that was introduced in 2015 and 16, that was just an interim solution. It's not a long-term solution. Because they had other issues. That's why we Malaysians, we forget mudah lupa. So probably the younger generation is also important for them to understand whatever policy that is being introduced today, you will not see the results tomorrow. You will see probably the next 1 or 2 election cycles. I like to use the word election cycles because politicians, most of them, they are only interested about election cycles. Everyone is the same. The past, present, future government, they all be the same. Okay, so that is why it's important for us to understand what's happening. So these are the issues. But of course, they have also given on-call allowances. Of course, it was previously at 9.90 cents on the weekdays per hour. MMA asked for 25 ringgit. But of course, there's an increment of only 40%. But of course, we do not say much. We also thank the government for that. But at the same time, that's not our expectation. But we feel that they should have allocated more. And in fact, we have given them a suggestion that remove the sugar subsidy. Okay, the 500 million you're saving from there, which is also, sugar is also causing so much of a problem to the country, right? So we do that. But of course, they didn't do that. But at least we are grateful that at least there's a 40%. But we do not have to fight for another 14 years to get another 40%. So we just hope there will be a periodical, at least every 3 years, you just increase slowly so that you do not have a burden to the fiscal budget.
Ideally, how many doctors should the country have? I mean, in the public sector, let's just go on the public sector. How many should we have? What is the ratio of doctors to the amount of the population?
Of course, there are ratios by countries where they're looking at the overall in the country, like 1 to 400, 1 to 500. But we must also understand those ratios we cannot take literally. Like for example, it must also be based on the patient burden. What is the number of patients that they're seeing in one facility? Like for example, if you look at some of the hospitals are totally overwhelmed, like HKL, or most of the major hospitals in the major cities in the country, they are totally overwhelmed. So do we have enough doctors to manage them? Definitely there is a maldistribution. Okay, maybe some places, in some departments you may have access, but some places in some departments may have massive shortage. So that is why the manpower planning, the manpower mapping is important.
It kind of reminds me of during the budget, the allocation for 2026 is going to be 46.52 billion, right? It's a bit of an up from last year's 45.3. But do you think this is, despite the 2.7-2.8% increase, do you think it's a realistic figure? Because now then that also we would have to think about, where does this money goes into? Is it going to be into hospital upgrades or digitalization, or perhaps even into workforce? Because you were just saying that workforce seems to be the problem now in the industry.
You see, but when we say workforce, right, of course, if you say 46.3 billion, it is just an increase of 2.8% from last year.
46.5.
Unlike in the previous 2 or 3 years, the increase was double digit. Okay, so MMA's vision and request from the government is that for the public healthcare sector alone, it should be at least 5%. Now it's just 2.2%. Okay, we are still short of 2.8%. But of course, you cannot increase immediately. There must be a plan to slowly increase. So in the last 2 years, when it was given 11%, 10%, we were happy. We thought, there will be a continuous increase, and so that we can match at least WHO, so that the system is underfunded, right? So at least more funding will come in. So now when the money comes in, of course, the development budget is only 6.5 billion. And then of course, this time it was quite interesting to see that SKMM has given 650 million to improve the internet connectivity infra, which is very good. Because we feel that sometimes there could be lots of overlapping in different ministries, right? So probably this is where the Ministry of Finance should look into every ministry, whether this particular budget can decentralize, probably help the Ministry of Health. So definitely Ministry of Health is one ministry that other ministries must help. Because health is not only the Ministry of Health problem, it's a whole of nation, whole of society problem.
Okay. And then you touched on the sugar part just now. I would like to go back to that. Now, there was an argument regarding vape, right? If you remember, they said about vape should be, increase the tax on vape products, but that wasn't the case.
This time around. They suggested 900% tax increase, but there was no such announcement.
Yes, exactly.
And it's still, whether or not how things are going to progress on this is pretty much up in the air in terms of the banning, the impending ban. But I suppose the burning question, pardon the puns lah, the burning question is, why, not just from the MMA side, but why the rush or the haste to ban vapes as opposed to cigarettes? Because, numerically, I might have the figure wrong, but I don't think we need to be experts in this lah. More people have died from cigarette smoking. That's a known fact. That's no secret. I just looked at rough figures. It kills about 27,000 people a year in Malaysia alone. 20,000 deaths a year. And you contrast that with vape usage. There have only been 5 deaths, at least in a year, and they were still unsure whether those were directly related to the consumption or the usage of these electronic devices.
Yep.
And it's been promoted as a harm reduction tool lah, for the lack of a better word. So the figures don't really add up. In our opinion, the figures don't add up. Why the rush to ban the vapes instead of like cigarettes altogether, doctor?
That's a very fair question.
Yeah.
And as usual, we can always agree to disagree.
Yeah.
That's what in a democratic society is.
Yeah.
And there's nobody's right, nobody's wrong.
Yeah,
but ultimately, all the statistics you mentioned,
Yeah.
there's somebody behind that.
Right.
So that could be one of our loved ones. When it's one of our loved one, the statistic doesn't play anymore, right?
Yeah.
Okay, let's look at cigarette. How long cigarette has been there?
Yeah.
It has been there for ages, right?
Correct.
Long before us.
Correct.
Probably I can't remember when it started, right?
Yes.
And I remember in those days they used to have advertisement for smoking.
Yeah.
But doctors used to smoke
Even
confidently,
for
right? In the
sports
50s,
events,
40s.
sponsors,
Sponsors, right? Then along the way they realize. So do we want to create another tobacco like vaping?
Yeah.
Don't we want to learn from our past mistakes?
Yeah.
Okay, past mistakes. So the thing is that it's better, but of course, ideally, we have to stop smoking as well.
Yeah.
I don't smoke. Okay, but at the same time, we have seen the history,
Yeah.
the outcome of that action of the past,
Yeah.
and we're introducing something so-called harm reduction, and we have seen how our school children are getting addicted,
True.
and they don't even know the solution inside the vape that's being used.
Yeah.
Nobody
Yes.
knows, right?
Yes.
There was a claim also on fentanyl and certain chemicals in Singapore. They found out, right? So the thing is that, do we want our children to be exposed to this? And what happens if our children is one of the statistics in that 5?
True.
Yeah.
I suppose.
So that is why it comes from there.
I suppose, among the young people, the appeal is that vapes, and I am a vape user, just make no secret about it. And the taste is, sweet, right? It's like candy. And I suppose that appeals to young people. And the packaging, they come in cassettes or all sorts of shapes.
Yeah.
But I just wonder if there are any alternative solutions that people can meet halfway. Regulators, associations, governments, and consumers, and the associations representing those advocating vaping. If there can be some place where we can meet in the middle. Say, for example, like how Australia is handling it. Australia, if I'm not mistaken, has somewhat banned the usage of vapes unless they are prescribed and sold at pharmacies, just as how you would buy nicotine gum. Is that a viable solution to stop children from vaping, or to prevent them, to limit or restrict their access to vaping, and for genuine adults who see it as a genuine smoking cessation tool? Is that a possibility?
No, but of course, for harm reduction, of course, when you talk about harm reduction, see, this is all the issue of addiction.
Yes, true.
Right?
Yeah.
It's an issue of addiction, including social media.
True.
Gaming recently, we have seen some horrible things in the past happen, right? So, addiction. So, of course, ideally, we do not want our children to start addicted to something at a young age.
Yeah.
Today is addiction to vape.
Yeah.
Tomorrow, addiction to what? Addiction is still addiction.
Yep.
Yeah.
Addiction towards bad habits, right?
Right.
So, of course, ideally, we want them not to do that. But we are not also going to demonize people who have gone into it. Could be for various reasons, like what you say, the is consumerism, right? And then for commercialization, they understand the behavior of consumers, the sweet, the taste, something to forget about your worries, for you to have cool. These are all, in a commercialized world, they take advantage of human behavior to put all these things to get yourself addicted. So that is why when it comes to the medical fraternity, this is what we are against. Okay, of course, then you have commercial element. So I think of course everybody can sit down, but the medical fraternity will not agree that we should allow it because somebody is getting addicted. Okay. That one will not allow that, because for us that, how can we help them to address their addiction problem? But not by telling them, now you take vape, better than cigarette. No, it doesn't mean you cannot substitute one harm with another harm.
Correct.
Harm is a harm. So of course, like what you said about Australia, of course that is recently introduced. It was just I think 1 or 2 years ago introduced. It's still very new. But if it's really working, it's very controlled. Again, Australia enforcement is very good. Okay, enforcement is very good. It's not only in the law, They really enforce the thing, and the public is also very scared of enforcement. So the question is that, can we do that here? Look at the cases. I think I also issued a statement where one pregnant lady was pushed in one of the restaurants when they told one of the patron of the restaurant not to stop smoking. So in these kind of places, you can see how the public can also behave to a pregnant lady, right? So when you look at all those things, so we have to ask ourselves, are we ready?
Exactly.
Enforcement.
Exactly. But enforcement also plays a part where, it's also part of the part where the money goes into from the allocation, right? So we've been talking about, increase perhaps the GP fee, general practitioner fee. That's one. But still, right now it's still at the floor price of 10 ringgit. Money goes into hiring more contract doctors. Money into upgrading hospitals and clinics and more tech devices or systems to improve. But also now about that funding, right? It needs to be managed fairly. And when it comes to enforcement, that's another additional allocation pula. Because then the government will need to come up with a new mechanism of how do we better carry out better enforcement. It's not just I think do we still have that system where you can take a picture of someone and then upload it on the system in the apps? What's it called again? Ada dulu time when we just started the banning of cigarettes in eateries and public places. I forgot the name of the app.
Okay, there are a plethora of apps that why couldn't they just put it all in My Sejahtera?
Exactly.
Like one government super app. I've written about this and nothing's been done. So the other day, a policeman came over to me and said, "Oh, have you tried our panic button app?"
Oh, really?
I was like, oh my god! I thought he was there to spot check me or ransack my car. He was like, no, actually I'm here. I want to introduce you to the emergency app for police.
What's it called?
Oh god, we'll get back to that. But I said I will try to download it. But when I think about it, we have a MyGPJ app. But I think
many government
apps. So predominantly we have My Sejahtera app, which I think almost every Malaysian has installed since the pandemic. Pretty much, the majority of Malaysians have installed it. So let's go back to. I think we've digressed. Let's go back to the original
but that's
question.
a good example. This is what I'm trying to say. So many banyak duit spent on benda-benda yang unnecessary, we think, right? Because now enforcement part pun macam it's not so synchronized from one agency to another. But enforcement is good because if you talking about banning stuff like that, it requires money still. Now. So what do you think about that whole...
Okay, one thing about the GP fees.
Okay. Let's go to that.
Yes.
The GP fees, since Julie brought it up, right? The GP fee, it was just announced in the budget, but there's no money coming from the government.
Right.
Okay, it's basically, this is the first time that, to be fair to the minister and also the Prime Minister, this is the first time since his gazettement in 2006, based on the MMS proposal in 1992, after us lobbying from different government, finally the Prime Minister has the political will, and the Health Minister was strong enough to support. He understands the strength of the primary care, that finally it was announced 10 to 80 ringgit from 10 to 35 ringgit. The money is not coming from the budget. It's just from whoever going to patronize
Yeah.
the GPs, right? Okay, the rest of the funding, like what Julie you said, see, what is important is efficiency and productivity. Auditor General bertahun-tahun keluar report
Yeah.
Yeah.
atas ketirisan lah, all these things, right? Including there was a report on the if I'm not mistaken, on kelapa sawit, how much they lost, around 10 billion in the last couple of years, right? So it's very very sakit hati lah. Dengar 10 billion is gone, right? And then here for our doctors we tell, give lah few hundred million to our doctors, kesian diorang budak-budak ni kan, supaya kita tak nak diorang lari.
Yes.
So we want that, but then they don't do that.
Yeah.
You see, so ultimately is efficiency. You must track where is the money is going. You must track. Like one classic example, like what Azim said, MySejahtera.
Yeah.
Kenapa nak banyak-banyak app?
Yeah.
Why JPJ app, this app, that app, every
Yes.
app. Then you got My Border Pass app. So why can't you just make one super app? Because why you have already invested,
Yeah.
and all of us have downloaded,
Yes.
and all of us we know how to use it. But at the moment now, I think KKM is using it for a good reason, for personal health record, right?
Yeah.
So when you do that, do you need other fundings?
Yeah.
It's a wastages.
And what happens to MySejahtera now? Even I tak pakai dah MySejahtera.
Exactly.
Yeah.
So kalau katakan boleh pakai JPJ, I pakai sekali.
Yes,
Yeah.
exactly.
Berapa kita pakai?
Yeah.
Not much. What? Road tax,
Yeah.
your IC, your what do you call it, license, kan? So this is where the wastage is. So similarly, we hope that all these fundings that being allocated, it is used prudently.
Yeah.
You must track using a digital system or other ministries where if there's overlapping of funding should give to support the health ministry, so that how they can actually support the health ministry in terms of their manpower.
Yeah.
Yeah.
Where can other ministries also overlapping one, like for example, want to do another app, no need lah. Give that money to Ministry of Health,
Yeah.
and you just whatever additional features you want to do, you just pass it to MySejahtera and then do that.
Yeah.
It's very simple.
Exactly.
Yeah.
Ini yang kena marah lah.
Back to the GP punya fees kan. So now it's still at the 30 ringgit, right? Or
Now it's 10 ringgit is the floor,
floor.
35 ringgit is the ceiling for the last 33 years.
Okay. And then post budget, I mean this the budget proposal is to increase it or
Yeah, the budget is to increase the ceiling
to
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 80
35.
ringgit.
Oh, to
80 ringgit.
80 ringgit.
Tak banyak tu. Ni 33 tahun dah ni. 33 years. So, floor tetap 10 ringgit.
Okay.
Tetap 10 ringgit. But of course, this is just a policy announcement. This whole thing has to go through the process of gazettement. So, we, MMA is just, we believe that the government will gazette it probably by December or January.
Okay.
So, of course, then only we can start charging. But it doesn't mean that doctors suddenly going to increase because why? We're also very mindful.
Yeah.
So, but patient pun, we know our patients, what is the affordability? I say healthcare is all about affordability. And then today, if you look at the GP practice also, there are 10,000 plus clinic. From the 10,000 plus, I would say 30% are actually bleeding. Another 30% actually just break even, okay? Only 40% are doing well. So basically, there's a market difference, right? So definitely, people will throw prices to survive.
Yes.
Cannot blame them. Okay, so because of that, all of us are very mindful. Because we put very high, patients won't come. Because patient ada banyak tempat.
Betul.
Sekarang, what patients will do?
Yeah.
They can go, Malaysians, they like to clinic hopping.
Yeah. Yeah.
One clinic hopping. They can also go to
It's actually a refreshing
Yeah.
term.
On Friday night, it's club hopping. Pub hopping on Friday night. On Monday morning, it's clinic hopping.
clinic hopping ada juga. So dia pergi clinic hopping. Lepas tu dia mungkin pergi dekat apa tu? They can even go to KK.
Because I do that.
So you see, maybe there are reasons why they do hopping.
Yeah.
Maybe they don't like the services, or maybe it could be a pricing, or maybe it could be something they're hoping for, they never get the expectation. Could be many reasons, right?
Yeah.
But hopping itself doesn't solve the problem.
Yeah.
So because of all this behavior of patients, so we GPs be very careful on the pricing. Even though even if you give, let's say Prime Minister said, okay lah, I give you 10 to 200 ringgit. Nobody in the right mind will charge 200 ringgit. Nobody will come. See, I can put what price.
True.
But today you have excess
Yes.
Yeah.
of the clinics, right? So patients can choose.
But isn't it a common practice for private GPs kan? If they charge 30 ringgit, that's the nominal fee. Usually that's what they charge me when I go. That okay, we're going to charge you 30 ringgit and because it's controlled. Tapi where we are going to kind of main harga or play around with the prices is at the meds. So maybe if I went to the pharmacy to buy Bena, okay, it's 8 ringgit, 10 ringgit at most lah. But at the clinic, probably it's half a bottle. And then they probably charge me 15 or 20 even. So isn't it just another way of clinics earning extra money.
That's true, Azim. True in a sense, because the fee was suppressed for 33 years.
Yeah.
So what happened is that everything cost has gone up, right?
Yeah.
So they cannot increase the ceiling. So what they did, they start pushing the prices to the medicine.
Yeah.
Because here you cannot naik kan.
You
So
cannot,
sekarang,
yeah.
because now this one you have go up. So what will happen is that while the consultation now, maybe in the future the doctors will start charging 50 ringgit consultation. Okay, let's say you have seen a GP. Let's say for example you went to see a GP, you pay 80 ringgit.
Yeah.
Okay, then 30 ringgit consultation, 50 ringgit is for your all four, three or four medications they're given you. So what's going to happen in the future? You will still get that 80 ringgit. So now the 30 ringgit will go to 50 ringgit consultation.
Yeah.
Of course, the medicine will reduce to 30 ringgit. Because if let's say now you have been paying me 80 ringgit, suddenly if I put 100 ringgit for the same problem, you won't come back.
Yeah.
You will never come back.
That's true.
You will never come back. So that's why we will always see very careful. I pun tak nak hilang Azim ni. Nanti Azim hilang, Julie pula keling hopping, habis. So of course we will lose our practice. So we will be very careful.
This is an
Really
interesting
I
conversation.
think I've been hogging the microphone.
Aku kena tangkap pula. Okay, so now talking about, so this is a very interesting conversation, but there's also another conversation that we would like to highlight, which is about doctors who have been overworked and undervalued. This is an issue everyone has been discussing about every year, right? We keep hearing doctors working over hours, like 36-hour shift. Of course, they will feel burnout. We corporate people working every day pun would burn out. Imagine doctors, right? Has anything really changed?
Of course, in the last couple of years, there are many attempts to reduce the working hours. Okay, in some department like anesthesia, if you do on call, the next day you are given off. In some department, the 36 hours is still ongoing in many places, depending on the. So I'm telling you, depending on the facility and depending on the department, depending on the workload. Okay, you can see the 70% of the facilities, the 70% of the healthcare burden is in the government facility, right?
Yeah.
And then you rightfully say, even you're working in a very nice air-conditioned office environment, 9 to 5. After 5, say, hey, sorry, I'm out. But can you imagine in the healthcare, whether you're a nurse, you're a medical assistant, or you're doctors, right? Even though the shift finishes at 5 o'clock, can you say, Encik, sorry nanti tunggulah seorang lagi datang, saya boleh balik tak? No, we don't do that. From the time immemorial, we do not do that. You know why? It's somebody's life. So we always give ourselves for the patients. That's how we were trained from medical school. Same training, right? So this is where the government has to take this very seriously. Because why you will get burnout. And today, to be fair to the younger generation, right? The way how we bring up exposure every generation is different.
Yes.
It's not fair to tell them, dulu saya boleh buat, kenapa saya tak boleh buat?
Yeah.
It's not fair to say that. Our job is that how can we keep improvising? That's our job.
Just because it was done before doesn't mean it should be done again and still.
Just because in the past they allow smoking, it doesn't mean now we must allow vaping. Same thing, right? So we must improve.
I suppose that look, we had a prime minister who was a doctor for good 22 years, and partly because he is also a someone who advocated industrialization. I think that was the time when Malaysia was experiencing rapid growth. So everybody across the board, not only doctors, were working overtime, and that is intrinsic to Asian culture. Maybe not just Malaysia, maybe to a certain extent China, Singapore, Japan. Things have changed, and we want to improve the working conditions for doctors and other professions as well. So what would you suggest? Would they need more, say, increase in annual leave, more incentives to travel, or to other benefits and perks, especially for the government doctors, right? What would you suggest? Maybe it's a dollars and cents question, and we'll get to that in a second. About those who are going abroad for specialization. These are talent that the government funded, and this talent is going abroad. So coming back to the original question, what would you suggest to improve the working conditions for doctors, especially those in the public sector.
Okay, so basically, if you look at public sector, right, there are 3 reasons why people leave. Okay, number 1 reason mostly is internal. Is the push factor is the one that people leave. The pull factor is very small numbers, right? So what are the push factors? One is pay scale, salary. Number 2 is workload, beban kerja. Okay. Number 3 is career pathway. Okay. If they say, okay, fine, we understand the kekangan budget, you cannot increase what MMA asks, but you only give 40%, we understand. Okay. We understand you got a fiscal limitation. We understand. Okay. Even though we don't agree, but we understand. Okay. Workload. Okay. Workload is manpower planning.
Yeah.
You plan your manpower. You come out the dashboard. You come out the norms. Okay. You really look at the map and see. Okay, what is the distribution? Where is the load is very heavy? Can we push people from here to there or not? So this is what they should do. And then every department, the head of department, they know exactly what's happening in their department.
Yes.
So how do we have a positive working environment? Okay, certain things are intangible. The leadership. Okay, how does a local leader in that place, whether Pengarah Hospital or the head of department, that creates that environment that you feel happy to go back to work the next day.
Right.
Then you know that, oh, even though I'm working here, my family is taken care. Maybe the government should, maybe some of them they are doing that. They should provide a nursery for the young mothers. Okay, young mothers in the workplace so that they don't have to worry about the child.
Yeah.
Okay, then when you're coming in there are many of them will have a very clear, these are all bright people, right? They've done very well in their Form 5, Form 6, and then they've gone to the medical school, and then they spend 15 years of their prime time. That means from 20 to 35 years old, when everybody is enjoying doing everything, all stuck in the medical school and they're stuck in the hospital, working 36 hours, and then when you're 35, you're earning this much, right? Then they see their colleagues all, hey, I had got a better life outside.
Yeah.
5 years I go back, but here you are stuck. And you must understand, working in the hospital can be very depressing.
Yeah.
You only see people who are sick. You see people who are dying. You see the family members who are down looking at. So it's can be depressing, right?
Yes.
So how can we help them? Okay, for example, those doctors who are pregnant.
Yeah.
Okay, the system doesn't allow them to carry. I mean, they have a kekan, the system whereby if you're pregnant, you must complete. Otherwise, you have to defer certain things.
Okay.
Okay. So there are certain administrative things where the government can look into to solve. You can't solve all problems, but at least list down 10 issues. Then you see that 10 issues. Yang mana yang tak memerlukan duit?
Yes.
Budget. So can we improve this? Can we improve that? Okay, you know money is a major issue. Fine. But let's look at other areas. Is it difficult to put a career pathway? Put a career pathway. If a young doctor comes in, they know, okay, I finished my houseman, medical, I want to be a surgeon. Okay, what is the career pathway? Where can I do that? This is where Singapore is good.
Oh.
Why they attract our talent? They're very clear. Oh, what do you want to become? You want to be cardiothoracic surgeon? Okay, this is the pathway. You do this. You want to become a family medicine physician? This is the way. So when you make it very clear, very transparent, promotion. Tak payahlah, you can bodek-bodek. Okay, isn't it? You must be very transparent. And when 3 of us are working, 3 of us should know where we stand. We 3 of us should know where we stand. Where is our standing in terms of our performance, and who is going to get that promotion. It should not be, oh, I know my boss. I'm not telling it's happening lah.
No.
Okay, it could be isolated. It could be very isolated. Okay, it should not be like that. Then you both will feel demotivated. Apa ni? I do all the work. Dr. Arasu yang dapat.
Yeah.
You know,
True.
so this kind of simple things, it makes a lot of difference.
But how bad is the brain drain right now?
I do not have exact statistics on what is the level have gone to overseas, but of course you can see in terms of the number of medical officers that have resigned in the last couple of years, and also the specialists that have resigned in the last couple of years is quite big. Whether they resign, mostly have gone to the private sector, and maybe a handful of them have left the country to go overseas. Okay, they find better things outside.
Right.
You know, it's not to say everything is good outside also.
Yeah.
Sometimes when they go there also, then they realize, oh, it's not as good as what we think, depending on which country you're going, which department you're going, right? So based on all these numbers, I think for Malaysia, we must value and appreciate talent.
Yeah.
That's true.
We must.
I think big on the agenda also among young doctors is workplace bullying. I just cannot grapple as to on why doctors, among all people, especially senior doctors, will engage in workplace bullying. I don't know, maybe in college people did some ragging, just to build characters. But these are full-grown doctors, with decades of experience bullying young, housemen. Why? Why does that happen?
Okay, it's a very interesting question you're asking me. Okay, basically it all goes to behavior and past experience. Probably they've molded. Some of them, they may not realize that what they're doing is also a form of bullying.
Yeah.
Okay, in my time, raising a voice is accepted.
Yeah.
There's also a physician in the late 1990s. He used to throw a file if you come late to.
Yeah.
Very famous. I don't mention.
Okay.
So very famous, but he's very good physician. Very firm, very disciplined, and he has trained many good physicians under him.
Yeah.
Okay, so I've seen him how they do that, but that was a norm at that time. Probably they did that kind of discipline to do that. But things have evolved.
Right.
Yeah.
Things have evolved, right? So maybe like what you say, some of them, because of that, they don't realize what they're doing is wrong. So this is where the system must comes in.
Right.
Okay, of course the government, they have the helpline. MMA also, we have a help dog. We launched in 2018. Any doctors having this, they can call MMA. We'll keep them anonymized and then we try to help them. So the system must be there. So the important thing is that when there's a report, there must be a very transparent investigation.
Yeah.
Action must be taken. Not necessarily every complaint they're correct.
Yeah.
Okay,
Yeah.
it must be a very fair investigation,
Yeah.
transparent.
Yep.
And then if the complainant is not correct, we must tell them why is your complaint is not valid.
Yeah.
If the complaint is valid, very clear, must take action.
Yeah,
Again,
exactly.
enforcement. Where we are failing most of the time is we got beautiful papers, beautiful SOPs, everything. Tetapi penguatkuasaan dan hasil tak nampak.
Yeah.
Most of the time that's the case. On paper, everything looks good.
Yes.
So now, I want to go back to the part where you mentioned the government clinics or government hospitals overflowing with patients, or maybe not enough of medical practitioners. Do you think that there could be more public-private partnership? I know currently there already are. Like I only know this because my mom is a renal patient, right? When she was diagnosed, of course, kena buat fistula tu kan.
Yes.
And sedang, biasalah, it will take them a couple of months to get the appointment. So they appoint a hospital near Bangi, where I live, a private hospital to do the fistula. We just have to pay $500, right? But it's limited amount of time. Dia bukan sepanjang masa. So now, do you think that is a good idea actually, because we're not actually coming from a rich family. Even for other B40 families pun, renal patient in Malaysia sangat ramai. Now, where do you think that at what stage are we at right now? Do we have enough public, private? Are we at the stage of borderline, underline, or yeah?
I think what you said rightfully, Julie, is good that is coming from the patient's family perspective. You understand the value of private partnership, right? If I say, then they will say, yeah, like he's a private sector one. Of course, he wants a public partnership. But here you realize how your mother benefited this.
Yeah.
Otherwise, a long waiting time, right?
Yeah.
Long waiting time. Unless we become a part of the statistics, we feel it, right?
Yes.
So having said that, of course, the government has done a lot of public-private partnership. One classic example during COVID-19, how the COVID vaccination, they got the GPs involved. First, they were running all the mega PPVs, right?
Yeah.
But when the GPs were involved, that's when we had the highest number in the world in a short period of time. And then we have successfully done with SOXO. SOXO screening started in 2013 with the GPs. Health screening started 12 years ago. Okay, they've done that. And then private partnership. For example, foreign worker screening. It was done. Of course, that is funded by the employers. But SOXO, of course, employees funding. Okay, employees funding kan, EPF funding. Not EPF, SOXO funding. It's online. SOXO, yes. And then lepas tu, you have this Madani, Scheme Perubatan Madani. You have PKB40 from taxpayers. Okay, Scheme Perubatan Madani introduced in 2023, budget was 100 million. 2024, they gave a budget of, 2024 was 100 million. 2025 budget was 100 million, tapi they reduced 80 million for this year.
Okay.
For next year, they've reduced the budget to 50 million.
Yeah.
See, when your development budget is 6.5 billion, we know that you are struggling, right?
True.
You have a little bit of fun, but you want to do the maximum for that. But you already have enough private hospitals with enough bed capacity.
Yeah.
You have enough GP clinics, infra sudah ada. Manpower sudah ada.
Yeah.
You don't have to worry about your OPEX. You just have to buy services, right? So
Yeah.
this is where the government should do more. You focus more. So again, sugar subsidy buang. 500 million, right?
Yeah.
So find a way how actually this can be done.
Yeah.
So we need from the patients
Exactly.
who have benefited from that. See, if we speak, they say, private sector speaking.
Yeah.
So if patients start speaking about how they are benefiting, then that will help to push the government to realize, because 70% of the burden is going there.
Yeah.
Yeah.
They are overutilized. Here is underutilized.
Underutilized.
A lot of capacity over there. So you can slowly channel some of the patients over here. Your waiting time will reduce.
Exactly.
You'll get a personalized care.
Yep.
Okay, and faster.
Happier patients,
Happier
happier
patients.
doctors.
Nobody will keep complaining to the government, right?
Yeah.
So throughout this podcast session, we've painted somewhat of a grim picture of the situation. But on the bright side, I'm flicking through Instagram and I see all these Malaysian visitors, expats or tourists coming to say, oh my God, Malaysia is amazing when it comes to healthcare. It's so easy to get an appointment. It's not like this back in Canada, it's not like this back in, the States or Australia or the UK. So, I mean,
I do agree largely part of that.
Yeah.
I do. Because
Yeah.
I am taking care of an ailing mother. I mean,
Yeah.
taking care of a renal patient is not
Yeah.
easy,
Yeah.
right?
Yeah.
But I do largely on that, I do agree. But
Do you agree,
Yeah.
Dr. Rasu, with what the Mat Sallehs are saying about Malaysian healthcare? It's earned a lot of praises on social media, and I'm surprised because like us as regular Malaysians and newsmen and journalists, we look we see like it's quite sad and the underfunded, like you said, workplace bullying, underfunding, development budgets and this and that. It's like wow. It's overwhelming and it's put a lot of strain on the national budgets, and despite that, it's still not enough. So what are your thoughts on how these Westerners are viewing Malaysians?
My first answer was we have a very good healthcare system in terms of accessibility.
Yeah.
I said what was developed in the 1970s produced results.
Yes.
But that system cannot take us to the next phase, that is the current issues.
Yes.
Yeah.
Right. So I would totally agree with these Westerners.
Yeah.
That when you start traveling to a lot of countries, you will start value what we have in Malaysia. We are one of the very few countries where our public-private is there. You can access to the private sector without any appointment.
Yeah.
Okay, you can have access to private sector without any appointment. In the worst scenario, you don't have money. You can still go to any of the emergency department in the public sector.
Yeah.
Even in the private sector, they will not deny at least the first line.
Yep.
Okay, they will not deny. It's not going to happen in many other countries, right? So definitely in that sense, definitely I would say we are definitely one of the better health systems in terms of accessibility.
Yes.
So what we are talking is that we should not be very complacent. We know the system of 1970s cannot cater for the issues that we are facing now. It has solved that problem very well. That's why in the fast leaders we agree. But now a lot of issues we are having is legacy. This reform should have started in the 1990s. Okay, in the 1990s, early 20s, it should have started.
Correct.
The government has been speaking about national health financing way back in the 1980s.
Right.
And now, that time I was in the primary school. Now, I'm a GP. Okay? After 40 over years, we are still talking about that. There have been so many governments have changed in the last couple of years, right?
True.
So we must agree the system is managing it,
Right.
but it is under a lots of stress.
Correct.
But it is not only the issue of Ministry of Health, it is a whole of society, the whole of a government, everybody's responsibility.
Exactly.
We must also have the health ministry to make sure that the government, other ministries start looking into that. Hey, we must support them
Yep.
in terms of the manpower, JPA, MOF, must find ways how to allocate more funding, and then that funding must be managed and utilized efficiently to achieve its target objective.
Right. No, I would agree that the healthcare system in Malaysia, generally, they're good, right? Especially if you have someone with critical illnesses that will cost you thousands of ringgit a month. Whereas I'm not paying a single cent for my mother's appointment in hospital. And so now, but I think the problem with that is you have to sabar sikit lah. When you go to government hospitals, the crowd, the appointments, the waiting time, emergency takes you like half a day, the whole stress. Now, for someone who's not willing to go through that ordeal, right? If you can afford it, you use the insurance and go to a private clinic, private hospitals. But the thing with that is now the rising costs
Exactly.
of healthcare. Insurance premiums are increasing now. But do you think that the government should step in more to regulate these medical changes or charges in the private hospitals?
Of course, the cost is going up for various reasons. Okay, we must remember that manpower cost has gone up. Okay, manpower cost has gone up. So we must also, what are the cost drivers in the cost going up? Manpower cost has gone up. The disease burden. Unlike 30 years ago, our habits have changed, right? So what we have been doing for the last 30 years, the way how we eat, what we do, now is catching up with us. NCDs, non-communicable diseases, diabetic, hypertension, cholesterol, obesity. We are the most obese nation in Southeast Asia, right? We take lots of sugar.
Nasi lemak, cheese, pisang goreng,
sedap.
cheese, keropok cheese.
Okay, we are safe for now. For now, we're alright. For now, both of us are okay.
Dulu start sebenarnya tak ada kolesterol.
Yes.
Hashtag. So basically, all these things is causing burden, and then we are becoming aged population. So the longer you live with all this disease burden, it's going to be more expensive to take care of you.
Yeah.
So definitely the cost is going to increase because the cost increases once you fall ill, and then you leads towards complication. Also because of we do not take care of yourself, right? So to manage that, the cost goes up because your manpower cost has gone up. Your latest new technology, your medicines mostly imported. So all these costs will eventually go up. We have to face the fact. But now, how do we manage this cost? Healthcare, we must admit, is not cheap.
Yeah.
But we must make it affordable and accessible.
Right.
So that is why in the healthcare system, especially in the private sector, it's privately funded.
Yeah.
Right? Privately funded, it has to be sustainable. As I was telling earlier, even though you give GPs 200 ringgit, they don't want to charge you 200 ringgit. Because we are very careful. Affordability. Otherwise, because you have a public sector. And people always compare, satu ringgit saya dapat macam ni. But they don't understand that is heavily subsidized. That's why they cannot move anymore, because heavily subsidized. For every 1 ringgit you're giving them, for every illness, right, there will be thousands of ringgit be subsidized for certain things. So coming into that, of course, now we can see the government has stepped in with the reset. The minister has formed a joint meeting with the Ministry of Health and also MK2. Right? So that initiative is there with Bayanagara. Everybody is involved. Right? Of course, they are talking about regulating the private hospitals cost. The private specialists in the private hospitals, they have been regulated from 2006. The fees, when you have a bill, the bill for the private specialists, memang they regulate.
Right.
It's all specified, how much they can charge, what they can do, all regulated. Now the question is the private hospitals. So this is something that, of course, government is talking about. DRG, there are many initiatives they're talking to address that. So our view of this is that it's good that we acknowledge the issue. Just like in healthcare, we acknowledge you have a problem, you have a symptoms. Now we have diagnosed what is the thing.
Right.
The diagnosis must be correct. If you diagnose wrong, your treatment plan is wrong.
Yes.
Okay. You will sometimes diagnose a bit more complicated diagnosis, then you must also make sure your treatment plan is also managed very well. So like DRG, we must have enough data. Okay, we must have enough data from private and public, and to make sure that probably they should look into the national DRG, not a piecemeal for a private sector DRG. Tak boleh. You must do a national DRG so that we know the cost metrics across, whether you're Ministry of Health Hospital, Ministry of Higher Education, Ministry of Defence, and also Ministry of Health, and private, all must be the same. Okay, and then in terms of regulating the private hospitals, they should look into how they want to regulate. Maybe the cost in Klang Valley, hartanah di Klang Valley tak sama macam dengan di luar bandar.
Yes.
Right. So all these factors has to be looked in. It is not as simple, but the good part is that there are conversations taking place, meetings are taking place. So even in fact, MMS initiative to set up a grievance mechanism between the private specialists and also the insurers and hospitals also have taken place. So there are lots of conversation going on because we understand ultimately the entire system is all about the patient. It's all about the patient.
True.
Julie, we're almost out of time.
Yeah.
Almost.
But we're almost at the end of the conversation that we wanted to ask. We asked most of the questions we wanted to.
Yeah, we've done most. But you know, there's so many follow-up questions, but this is quite an interesting conversation. Okay, I'm going to let you have the next few questions.
Sure. We've been talking about AI, digital technology and stuff like that. So let's look forward to the future, right? Now, Doctor, do you think that digital health, things like telemedicine or AI, actually help ease our current challenge?
You see, technology will definitely help us. What you can track, you can measure. Today, you have your Fitbit. You track your steps. That changes your behavior. Right? Okay, you say, I must do 10,000. I must do 8,000. You track. So similarly, if you're having a diabetes, if you have a system to track your thing, that will change your behavior. You'll be more conscious what you're eating. So similarly, digitalization in healthcare is inevitable.
Okay.
It's good that the Ministry of Health is actually doing a lot of things on this, especially under Dr. Zul. He has put a lot of effort. They have the digital health policy, a digital health department, where they are putting in the EMR, in the clinic kesehatan, and then they have this Mais Jatra, where the records are given back to the patient. These are all very positive initiatives by the health ministry. Yeah? So we must also praise them for what are the good things they're doing. So this is the right way to do that. So the adoption of digitalization among the survey practitioners and also the patients are also very important.
Right.
Okay, telemedicine, definitely there's a huge demand for that, but we must not be too commercialized. A patient follow-up, okay, is okay. We must see, no matter what, the policy must comply to the ethics.
Right.
There are ethical considerations to ensure that it's not overly commercialized. Okay, right? Like for example, Ministry of Health do that. They do telemedicine for their NCD patients, follow-up patients, remote access. They do that. In Sabah, Sarawak, ultrasound, all they do. This is the way you should do that. Definitely, technology has a huge role to play. That's why I was telling earlier, when SKM said that 650 million be given to KKM to do that, it's a very good initiative.
Yeah.
This is the way you should do that.
Speaking of commercialization, I'm looking at the skincare sector. I mean, skincare aspect of the health sector. Sorry, you have dermatologists and you have beauticians.
Yeah.
Okay. Now, both of them, say for example, offer services like pico laser to get rid of.
It's such a thing now.
Yeah, it is such a thing, and some conducted by dermatologists, trained dermatologists, medical doctors, proper ones. Some are beauty centers who have this equipment, but you can see that the charging is different, and when it comes to beauty clinics, it's a bit of a sensitive thing because as certain people are very conscious about their appearance, but that's where such clinics or such beauty centers know how to
Find the market.
cari mangsa. Not cari mangsa lah, but what I mean, like in terms of how they charge. They will advertise on Facebook, okay, this one you do this treatment 200 ringgit, promotional, promotion 180, we slice. And then you go into the clinic and then suddenly they upsell you and you end up walking out of it with a 2,000 ringgit package. So, these are the things that are, I think when we're talking about commercialization, that's the concern, isn't it, doctor? That people are getting a lot of wrong information or misleading advertising from certain not all. I'm sure there are really genuine dermatologists and really genuine centers out there, but the ones we see on a lot of the ones we see on social media, and you look at the reviews, people are complaining and saying, I came in for the 88 ringgit promotion, and then then they forced me to take something that was 800, 10 times the amount. Your thoughts on this, doctor?
Okay, basically, right, you have one sector is heavily regulated.
Yeah.
The private healthcare, you got 54 laws and regulation regulating it.
Yeah.
You have one sector not being regulated.
Yeah.
You have one sector, because there's a regulation, patient can complain to MMC, patient can complain to CCAPS, KKM, actions being taken.
Yeah.
Sini siapa ambil action? Direction.
Yeah.
So here they know the demand is there, the consumer behavior they understand. Of course, it's fair, everybody wants to look good. There's nothing wrong with that.
Yeah.
Correct.
Okay, but this is where the government, we have been highlighting how many beauty centers, Suntik, this one got complication, meninggal.
Yeah.
There's so many cases. We get that on and off, we get. But what happens?
Yep.
Yeah.
It's still flourishing. That means penguatkuasaan.
Again,
Satu,
back to the enforcement.
enforcement. Second thing, adakah undang-undang? Maybe there's a loophole in the law that you cannot take action against them. So for us in the private sector, everything is micromanaged. The way I talk, patient don't like, they can complain. One ubat salah, tersilap bagi ubat. Also you can akan saman. And for us to practice, we have to take professional indemnity insurance. So there's so many things. Imagine, You do medical school, you do your housemanship, MBO, pakar. Lepas tu baru you can do that. Here you open a beauty center. Tomorrow mana tahu Azim buka satu beauty center. Get some beautician there. You can do that.
Yeah.
You understand now? So this is where kelompongan lah.
Correct.
You know, this is where the loophole, they find the loophole to that. But we must protect the consumers. We must pity them because why sometimes in that situation, cannot blame them. So we must make sure that they are protected. So how we want to protect them? Of course, misinformation. Lots of misinformation. Banyak sangat pakar-pakar tiba-tiba keluar menjadikan. Kita pun takut juga nak bahas dengan orang. So these are the issues.
Verify pun gets tougher and tougher. Gets more challenging.
Yes.
So with that reality, there's a good part, there's a scary part. I think like mostly it's scary, but still we need to do better than this. It's 2025. Now, 10 years from now, what do you wish Malaysia healthcare would be? Nanti.
Okay, very simple.
Yeah.
We know the problem. We know the solution. We should just do it. As I told earlier, system of 1970s has achieved its objective. Now we are moving to the next era. The next era started 10, 15 years ago. NCDs and obesity and also aging, right? We have a solution in the form of health white paper that was passed in the parliament in 2023. There are 4 pillars, right? The plan for 10 to 15 years. They have to start doing that. That's all. They will start doing that to prepare for the future. Otherwise, in next 5 years' time, you'll be talking to another MMA president and he'll be telling the same thing also.
One final message. Perhaps you would like to add on something. Maybe we haven't touched anything or questions that you wanted to answer, but
that we didn't touch on.
Yeah, exactly.
For
Maybe
me,
to the younger ones who've like lost hope, takutnya tengok perbincangan ni semua like very grim and scary industry situation. What would you say there?
To Julian, Azim, I think healthcare, especially your audience, or the younger generation, what they do when they're 20s and 30s is what that is what will determine how they're going to be when they are 10 or 15 years time. So health is everyone's responsibility. It's not the responsibility of a doctor. It's not the responsibility of government. It is our responsibility. Eat well, eat healthy food, you exercise, sleep well, and mix with positive people.
Oh, that's a good one.
So that's my message to our audience out there. And thank you, Vibes, for this. Sorry. Silap.
Bukan dah warna.
So thank you, Scoop, for this initiative, and we really appreciate. And I think this is one of the advocacy that we have to continue to do that, so that more people listen and they understand health is everyone's responsibility.
You know what they say, health is wealth. If you have so much money but then you're sick, then what's the point of living a life, right?
Health is wealth and wisdom. So thank you so much, Dr. Arasu. It's been such an enlightening conversation, and we hope to have you on board again soon.
Hopefully we'll have a different problem to discuss. And not the same one again and again and again. And thank you so much, you guys, for watching. Take care.
Take care.